Welcome to the pharmaphorum podcast. This is web editor Nicole Raleigh, and today I have with me Marc Buyse, founder of IDDI and One2Treat and co-founder of CluePoints. Welcome, Marc.
Thank you for having me.
Hi, this is Chris O'Brien. We'll be right back with the rest of this episode in a moment. I wanted to introduce you to the Biorossi Few and Far Between podcast, hosted by me. Few and Far Between brings you conversations from the front lines of drug development. Each episode features cutting-edge discussions with top biotech innovators and clinical trial industry experts. You can find our episodes on Apple Podcasts, Spotify, and other streaming platforms. Thanks for listening, and now back to the episode.
So, in today's healthcare landscape, there is a pressing need for quantitative methodologies that include the patient's perspective in any treatment decision. And Marc, who is one of the editors of and a chapter contributor to the first edition of Handbook of Generalized Pairwise Comparisons, Methods for Patient-Centric Analysis, recently published by the Routledge Taylor Francis Group, will be discussing with me today the finer details of this need during the episode. But before we sink our teeth into our chosen topic, Marc, perhaps you could introduce yourself properly to our listeners and provide some details about the road that led you to doing what you do today.
Certainly. So I have a degree in biostatistics from the Harvard School of Public Health, and I've been doing clinical research essentially for all my career. So my interest was mostly on biostatistical methods, which I developed, with others, obviously. And one of the methods that we worked on for the last 10 plus years, is a method that allows us to now incorporate the patient needs or the patient preferences in statistical analysis, which is, as you can imagine, a completely new approach, a very innovative approach, and a very exciting one as far as I'm concerned, because, as you know, there is a pressing need these days to include the patient in clinical research far more than was the case before.
Thank you, Marc. So if we turn our attention now to the book itself, again, the title is Handbook of Generalized Pairwise Comparisons, Methods for Patient-Centric Analysis. That book provides a comprehensive overview, it's safe to say, of an innovative and powerful statistical methodology that generalizes the traditional 𝘔𝘦𝘯𝘕𝘏 test by extending it to any number of outcomes of any type and including thresholds of clinical relevance into a single multidimensional evaluation. It also covers the statistical foundations of generalized pairwise comparisons, or GPCs, which are applications in various disease areas, implications for regulatory approvals and benefit risk analyses, and considerations for, as it's becoming clear perhaps to listeners today, patient-centricity in clinical research. So Marc, tell us how the book came to fruition, if you will, and a bit more about your editorial part there, please.
Sure. Yeah, so we started to write this book because the method is new, and I mean, it sounds complicated the way you presented it. The 𝘔𝘦𝘯𝘕𝘏 test, that sounds very barbaric. It's the name of the people who first proposed these methods a long time ago. Wisconsin was a statistician who worked on this new test in the 1940s. So it shows you that we actually reuse a very old method, but we extend it in a manner that is very innovative. And just, briefly, the idea of this test is to compare each patient who receives a treatment to each patient who is in the control group in a randomized clinical trial. So that's the main idea of this method. And it's very innovative because the comparison of these two patients, which we call pairwise comparisons, right? Comparing one patient who receives treatment versus one patient who receives control. This comparison, the pairwise comparison, in fact, can have as many outcomes as needed. So, for example, we can look at the survival time of these two patients. But if these two patients are still alive at the time of the analysis, which is, of course, a very good outcome, then we can look at their quality of life at the moment of interest. And if they have the same quality of life, then we can look at some other outcome that might be in a list of prioritized outcomes. So it provides a very general framework for comparing patients whichever way we like, depending on the clinical context in which the comparison is made. And so that is extremely powerful from a statistical point of view, but it's also very relevant to patients because we can take into account what matters to them. But your question was more about the book. We felt there was a need for a book to explain the methodology. And in the end, the book turned out to be very, very mathematical. I mean, there's lots of formulas in the book that's needed because it's a new method, although the idea of the method is old. You know, the details of the methods have been worked out in very great detail mathematically, but we also wanted to look at the method from a patient-centric point of view, which is completely non-mathematical, non-quantitative, if you like. So the first half of the book, or the first 2/3 of the book, is really math and, you know, developments, methodological developments of the method. The second part of the book is more, you know, how can this be used for patient-centric approaches in clinical trials? So that's the road we follow, being both very mathematically detailed, but also very patient-centric at the same time.
Thank you for that overview of the book, Marc, and I am sorry if my introduction to it came across as barbaric, as listeners will understand today. This methodology is very much treating the innovative. So the first part focusing on the mathematics, if you will, and the second part more on this patient-centricity. If we turn to your co-authored chapter with 𝘕𝘢𝘯𝘦𝘠𝘢𝘥 entitled Generalized Pairwise Comparisons for Patient-Centric Treatment Decisions, what more can you tell us there about this positivity of GPCs, if you will, and their role in patient-centric treatment decisions?
Yes. So again, I mean, the chapter I wrote with 𝘕𝘢𝘯𝘦𝘠𝘢𝘧 is really what we call a gentle introduction to GPC. What we fear is that because, you know, the implementation of the method may have a lot of mathematical aspects, we really want to, you know, give the impression that this method is at the same time very easy to understand. In other words, the idea of the method is simple, comparing one patient with another and doing this for all pairwise comparisons. So if we have a clinical trial with 200 patients, 100 patients were randomized to receive treatment, 100 patients were randomized to receive control. We compare each patient with each other in the other group. So that means we have 100 times 100, 10,000 pairs, right? So the analysis really consists of looking at 10,000 potential pairs of patients. And for each pair, we decide in that pair which of the two patients has the better outcome. And that's the beauty of the method. The better outcome, as I said before, can be, you know, defined whichever way is appropriate, based on as many outcomes as needed, which you can prioritize or which you can take all at the same level. So the method is extremely flexible, you know, as well as powerful from a statistical point of view. And that's really what makes it very attractive. As you say, the positivity of the method is that it can be explained to the patients in a very easy way, and also, by the way, to the doctors or the physicians who will use the method. And it does make sense when you explain the method far better than some of the complex models we use in statistics. As a you know, practicing statistician, there is nothing I dislike more than having to tell people, look, this is too complex for you. You know, you don't need to understand it. No, I think people need to understand, you know, not in great detail, but understand at least the concept behind the methodologies that we apply. Otherwise, it's very hard to get involvement of the patients in a trial if they don't understand the way in which the data will be analyzed. So our hope is that we want to make the methodology accessible to patients and physicians and other non-statisticians so that they can understand what is being done in, you know, sufficient detail to make sense of the results. And that's really why we wrote this book.
Absolutely. So accessible, comprehensible. It makes sense to me. But let's turn now to your other co-authored chapter, Regulatory Considerations for GPC Analyses, which was written with Samuel Salvaggio. And I was wondering if you could tell us more about that chapter and those regulatory considerations?
Sure. Yeah, I mean, regulatory considerations are important in our field of clinical research because, as you well know, drugs are only approved if they pass the regulatory hurdles. They have to be, reviewed by the agencies, and the agencies will grant market authorization only if, there is enough evidence that a drug is effective and safe. So when you develop a new drug, you have to do randomized clinical trials, typically, to show the value of this drug as compared with the best standard of care available. And, if you use GPC to do this comparison, obviously the agencies have to accept these results. They have to first, understand the methodology, understand all the details of the methodology, and be very comfortable with the fact that this methodology is valid from a mathematical point of view and also clinically relevant. And so again, this chapter in the book tries to address these issues. How can this method be interpreted? How can it be reviewed by the agencies? What are the aspects that matter to regulators? And we, of course, know what questions they have on their mind. The method is new, and therefore it will take a bit of time before it's accepted. It's already used, by the way, in cardiology quite extensively, but it's not been used very much in other disease areas. And we would like to extend the methodology to other areas of research, including oncology, which, as you know, is a substantial portion of the new drugs being developed are in oncology. So we want to extend the methodology to oncology and also to rare diseases. Why rare diseases? Well, because there's a huge unmet medical need in rare diseases, and because of the rarity of the disease, oftentimes the sample size, what we call the sample size, which is the number of patients we can actually accrue in the clinical trials, is by definition limited in rare diseases, and even more so in ultra-rare diseases. So in those diseases, we are in acute need for better methods, which allow us to analyze multiple endpoints in a single analysis and thereby increasing the statistical power of our analyses. So we believe that this methodology has huge potential, especially in rare diseases. That's why we wrote this chapter on regulatory considerations.
Thank you, Marc. So you've sort of preempted my final question there, talking about expanding out of extensive use in the cardiological field into unmet need areas like oncology or rare disease. So, as to my final question, if we consider the future, what would you like to predict, let's say, for want of a better word right now, for these quantitative methodologies? And indeed, I think an apt question would also be, are there further upcoming publications?
All right. Yeah, I mean, I can summarize my hope in a very few words. When we look at the quality of life in clinical trials, and of course, there are many ways of measuring quality of life. Either we measure quality of life as a kind of overall, quality, which is pretty hard to do because different people have different opinions as to what we mean by quality of life. But oftentimes we have more specific ways of measuring quality of life. For example, focusing on a specific aspect of the disease that really bothers patients, or a specific aspect of the side effects of treatment that also bother patients. So we have ways of measuring these things. And of course, it's vitally important to patients, these aspects. These aspects typically have been relegated to secondary endpoints, as we call them in clinical trials. So instead of having these endpoints which matter to patients in the primary analysis of the trial, oftentimes, typically, these endpoints are analyzed in addition to the primary analyses. And this, I think, needs to change. We want the patient-relevant outcomes, such as quality of life or functional scales or, any ways of measuring what really matters to patients. We want these measures to become the primary focus in a clinical trial. And by having multiple outcomes in the primary analysis, we can actually do this technically now. It was very hard to do in the past because we didn't have the methodology. Now we do have a methodology to allow this to happen. And so we really would hope that this will happen in the very near future so that trials become more relevant to patients. The primary analysis will include what matters to them, and that can be done in consultation with patients. So that would be my dream, if you wish, for the next couple of years. Perhaps by the time that the agencies accept the method, and by the time that we find, proper ways of including the patient-relevant outcomes in the primary analysis, if we can achieve that within maybe 2 or more years, that would be really a wonderful outcome. So that's my hope.
That's your hope indeed. Thank you very much, Marc. It's been a pleasure.
Thank you very much.
And that concludes another episode of the pharmaphorum podcast. You can find more information about this episode, including a download link and information about previous installments at pharmaphorum.com/podcasts. The pharmaphorum podcast is also available on Apple Podcasts, Spotify, Overcast, Pocket Casts, Podbean, and pretty much wherever else you download your other podcasts from. Just search for pharmaphorum and follow and hit subscribe. Of course, don't forget to visit our website itself, where you can sign up for daily and weekly news and analysis bulletins. And do follow us on Blue Sky and LinkedIn at pharmaphorum. That's all for now. Thank you for listening.